So I'm going to cover the needs of older persons in the community, relate that to healthcare models and systems, the importance of medical-social integration in dealing with this issue, the empowerment of the public, then the role of technology in unmet needs, and finally, how do we construct an action algorithm, group programs, using the most basic level of manpower in the community. So you probably heard of the ICOPE from the WHO. The ICOPE document, Integrated Care of Older People, is now is built on evidence to say that for older people we need to cover many domains, and this is suitable for people in developing countries as well as developed countries. And there's an app to go with this as well. So the domains they cover: musculoskeletal function, mobility and vitality, cognitive impairment, depression, psychological well-being, sensory capacity, age-related conditions for support of caregivers. So the issue we're dealing with in many developed countries, particularly places that are rapidly aging, is that people need health and social services. And from a person's point of view, you can't chop them into different systems. It's difficult to navigate. There's need for prevention and empowerment. You cannot rely on other people. You have to help yourself as well. So I'm going to talk about how each country, each place need to develop their own primary care model to integrate these medical and social elements. So here are some unmet needs. I think this is common to all places. That we have people who are frail in terms of cognition as well as physical capacity, living alone. And the problems they encounter are poor oral health, problems of hearing and vision, physical and cognitive frailty, poor psychological well-being, dependency in instrumental activities of daily living, problems with medication, problems with finance and care, and the frequent uses of hospital services. So I think this is really common to all aging populations. And our goals really the goals are to empower older people in health management themselves, so they can do a lot themselves in self-management. There are elderly centers in all countries to enlighten and empower these centers and their staff to organize activities to address these unmet needs. And then for the society to foster the development of a primary care model in the community that integrates health and social components, not necessarily focusing on family physicians or nurses or whatever, but going to a level that's even more basic before you get to the nurses, before you get to the healthcare professionals. So in order to do that, you have to have a community health and well-being screening. You have to build on existing network in your country or city, integrating both medical and social sector. And for the technology part, because of lack of manpower, technology always has to be used, you have to have an e-health platform as a key component, which covers the screening, the analysis, action plan, and intervention recipe. So basically, we're saying a screening tool that incorporates an algorithm, tells you what to do. So anybody can follow this. Before you, if you need to see a doctor or nurse higher up the chain, so you can write that in the algorithm. And the outcome evaluation is improvement in what are the parameters you're measuring, and also reduction in health service utilization. So this is a key concept of a desirable model. And everything should be automated as much as possible. So you have questions, you have simple measurements and so on, and then you transmit the data to somebody else. So you have automatic analysis and report generating. So in Hong Kong, we try to promote this concept as part of a project, e-health project funded by the Hong Kong Jockey Club Charities Foundation, where we make use of network community centers all over Hong Kong to achieve the highest degree of accessibility. And in the survey, we cover the multi-domains that geriatricians are familiar with. And we identify common problems, and then we write the algorithm what to do. So there's a survey, and then there's a blood pressure measurement automatically capturing and relaying the blood pressure to another site. We screen for oral health by asking questions, do you have chewing difficulty? And then if they says yes, then we can ask further questions. So these are the things that we try and cover. And there are about 10 questions. And whenever they answer yes, it triggers something, and then we continue the dialogue. So it's not as bad as it sounds, because on average, people only trigger 3. So it's manageable. So we tried to do this for 3 years with varying degrees of uptake. But here's a sample of what the problems we're picking up. So you can see that there's quite a substantial amount of unmet needs. So 38% chewing difficulties. Frailty is great at using the Frail scale, 5 questions, greater than 60%. Sarcopenia is up 15% using the Sarcopenia. Memory complaints, over 70%. No meaning in life. So this is 3 questions. Are you happy? Are you satisfied with your life? Do you have meaning in life? It's covering the 3 dimensions of well-being. 22%, so something that we need to do here. Problems with ADL, IADL 27%, polypharmacy 24%, and so on. So what did we do? We also found that because we cover many districts, the needs vary according to gender, age group, socioeconomic groups, types of housing and living arrangement district. The beauty of this technology is that you can target, the government can target the services to the areas with the most unmet needs. So this is a sort of diagram, very complicated, but I just want to point out an example. For example, if you have a poor memory, so this is the AMIC, it's 5 questions that is supposed to pick up mild cognitive impairment. If it's positive, then they progress to do a 5-minute mocha, and then they get, depending on the result, they get further investigated or then go to the NGOs for group programs, like exercise programs and so on. So you can escalate upwards. And if Frailty, Sarcopenia, we devise programs for them, and IADL can give them advice and so on. Medication, they just need to check. A lot of them are taking medication, it's like 4 or more, and if they answer yes, they basically have to take all their packets of drugs, which are labeled, to the center. And most of them, well, a lot of them, got it wrong. So we're doing really fundamental basic things to detect. And for example, chewing difficulties. So we can ask, is it dry mouth, or do you have painful teeth, do you have painful gums, and so on, depending on how they reply. Sometimes they would get told to see a dentist, but then we can make use of local resources to say there's a free mobile clinic, free mobile dental van provided by the government coming to your neighborhood like on Tuesday afternoon. So really practical suggestions that are tailor-made for your particular locality. So if you have dry mouth, so maybe you can just tell them to buy some sugar-free chewing gum in some shop that near them. So it's meant to be really practical, but you have to write your own for your own city or country. So the thing with the beauty of the automated system is quick. You don't need so much manpower. You can devise a system, and then you can eventually use it for your city. And it improves accessibility and use a step care approach. So before you get to the clinics, you can deal with a lot of problems already. And you make use of the existing community NGO centers. So the potential significance is that it promotes medico-social integration in the similar idea as the WHO ICOPE, which can be used for low-income countries as well. Although Hong Kong is not a low-income country, as far as needs of older people is concerned, I think it's nearly just like a low-income country. You have empowerment. The relatives and the center staff can help with these problems. And so in Hong Kong, policy-wise, there are these think tanks and government just thinking in a similar way. They all recognize that population aging, and they're all worried about the burden that results and what we can do about it. So, of course, future development can automate everything. You can do an app, you can do a voice-activated thing like Siri as well. And then we can link this system to community health centers, the one with nurses and doctors and hospitals. So right now, everybody just go into hospitals to the accident emergency, and so with primary care. So hopefully this system is going to cut down a lot of this accessibility issue. So this is just a summary in picture of what I tried to describe, this model. We're kind of in the middle of developing the technology. We haven't got there yet because we found that as we go along, we have to educate everybody, including our funders, what we're doing. So it's just to illustrate that using the data we capture, just talk about frailty and sarcopenia, we have to convince the policymakers why you're doing this, because they don't even know what frailty is or why you need to look for it in the community. So one thing that was useful with this project so far, we've demonstrated that because we automatically repeat this every 12 months, the people who are frail use health services more. So this is a very important fact to convince people why this model is useful. Here is another picture of what we did. We followed them up. So at baseline, there are people who are robust, prefer, and frail. These percentages are similar in other countries. But after 12 months, we try to do something. It's not perfect because we have to educate the NGOs to what they can do. It's going in the right direction because, for example, the percentage has changed from 18.1 to 17.9. But it's not significant, but certainly it's not going the other way. This is another bit of statistics we had to collect to convince policymakers that if you look at the robust, prefer, and frail group, there's a dose response curve in terms of hospitalization, SOP specialist outpatient clinic, general outpatient clinic, and daycare services. So you always want to reduce the utilization of health services. So then you can bring in the argument, well, we can reverse frailty, we can do things to make people less frail. But then you can introduce your programs. So you have to tell them that increased functional limitation, disability, dependency, healthcare, and then you can estimate the costs of if you didn't do anything. And as for public education, health promotion, these are the messages we need to tell people that could lead to functional limitation, is preventable and reversible, and can be detected easily. And then there are various recommendations. So in simple terms, what the public education part is also very important. So for policymakers, these are the kind of areas we emphasize. So I ought to stress, I cannot tell you we have succeeded. This is an ongoing effort. So this is just a diagram to show the overlapping of these three geriatric syndromes. So they're not the same, but it's just to give you some idea of what happens. These are using simple screening tools. So I want to focus particularly on sarcopenia and frailty, the programs that we have designed to be done in the community centers, a sort of evidence base as to why it's effective. And this is something we need, again, to show healthcare providers that this program that you recommend actually works. So for sarcopenia, we talk about all the adverse consequences. And so we have to do it properly with an RCT, which compare exercise with exercise and nutrition and a waitlist group. Because of funding, we didn't have four. So we use the Asian guidelines to recruit people who were sarcopenic. And the nutrition supplement contains HMB. So we did it for 12 weeks. And then we stopped, and then we followed people and reassessed them 12 weeks later. And we had body composition using DEXA, muscle strength, physical performance indicators. So not much difference in the baseline. This is just a randomization. But I just want to show you what happens. So this is interesting that we measured the lower limb mass. So the waitlist control group is the dotted line, so the mass went down. This dotted line is exercise, lower, so it's flat. So muscle mass our intervention didn't do anything to muscle mass. But if you added the nutrition supplement, the muscle mass increased. That's significant. If you look at leg extension strength, nothing happened in the control, but both the exercise and the exercise nutrition group went up in parallel. So there's actually no difference in the improvement. With 5 chair stand, both exercise and nutrition group, the chair stand time is reduced. So the physical performance improved equally for both groups. Physical activity, what they normally did, both exercise and exercise nutrition group increased their physical activity level, their normal physical activity level. So the interesting thing is that this program, which combines social and strength, power and resistance components, strength building components, with and without nutrition, they improve strength and physical function. But the interesting thing is that when you stop at 12 weeks and then you reassess everybody 12 weeks later, the beneficial effects of the strength and physical function can remain 12 weeks after. But the mass that was improved with the nutrition and exercise group, the increase in mass after 12 weeks totally disappeared after another 12 weeks. So it was only a transient thing. The muscle mass built up while you're taking the supplement, but when you stopped, there's no beneficial effect on the but this is the PhD thesis of Dr. Hsu's in the audience somewhere, published in Age and Aging. Now, what about frailty? What can we do with frailty? So we run an experimental community center called the Condenser Hub, where we try out all sorts of things. And 2 years ago, we looked at frailty screening to see what happens. And we found that we can pick up frail and pre-frail people. So the staff there designed a frailty prevention program, which has exercise as well as cognitive activities component, which was very popular. It's self-financing, they have to pay, but they came from all over Hong Kong, and they continue to do it for a few years. So we wanted to actually prove that, what does it do? Why do people keep coming? Because in a way we've achieved something, that they keep doing something. But we want to document what the exact benefit is, other than the fact that they like it and they feel better. I mean, maybe you could argue that that alone is important because it's a patient-related outcome measure. So basically, we want to measure the frailty level in physical and cognitive function. So the result of this is going to be presented by Dr. Ruby Yu in the other conference. We thought it was the same, but she's going to present it in the regional IAGG. So just to summarize that, after 12 weeks of this activity, the frailty status improved. The executive functions measured by frontal assessment battery score went up. And as I mentioned, the participation rate is very good, attendance very good, low dropout rate, and people have to pay and they still come. Right? So it says the program is ready to be adopted. I'd say it's ready to be adopted by other centers because we assessed this after the event, right? We created a program. So the comments are that this is feeling better, sort of physical domain, they felt better. This is cognitive domain, and this is social. They made a lot of friends. So this is some of the things that you can incorporate in community centers. But Hong Kong is just an example. There are other places which are adopting this line of thinking, and I can't really remember who did it first. But here is St. Louis. I mean, John can talk about it later, but essentially there's rapid geriatric screening in a computerized form with a management program. This is at the family physician level. So it reminds doctors to do some things. And then in Japan, they have a program called Cognisize. It's combining exercise and cognitive training. And they have run this program and they have good results, impressive results. And then in Singapore, there's a healthy aging promotion program, the HAPPY program, which is run in community centers as well. So it's adapted from the Japanese Cognisize program. And so it has exercise and dual task exercise and general advice on healthy aging and diet. Just to finish off, I want to say that opportunities exist in the primary care setting to address extensive unmet needs of older people by detection of geriatric syndromes, followed by community-based intervention programs. And we ought to use a medical social model, and this could represent the first step in a step care approach that link you to healthcare facilities with multidisciplinary healthcare professionals. So you start off a level below the healthcare professionals. I think this ought to be, eventually you can assess this, it's going to be rather cheap because you're building on existing centers. Thank you for your attention.